now. All right, so welcome everyone to our second Sunday conversation of 2023, presented by the Massachusetts MECFS and FM Association, also known as MassME. Today's program is titled Pacing for PEM, an OT and PT perspective on what it is and how you can use pacing strategies in your daily life. My name is Karin Dove, and I am a volunteer and member of MassME, and I will be the moderator for today's event. All right, I'm going to introduce the speakers now. So I'm really excited to have this presentation today with Amy Mooney, Sallie Rediske, and Melinda Maxwell. Many of you might recognize Amy from her presentation to us last year, and we're fortunate to have her join us again along with her two colleagues. Amy is an occupational therapist in private practice, specializing in therapeutic care for individuals with chronic conditions involving post-exertional malaise and post-exertion symptom exacerbation. Amy's Pacing for PEM guidelines and therapeutic protocol have been featured presentations at national and international conferences, continuing education programs for medical professionals, and patient advocacy webinars. As a caregiver for a loved one with MECFS, Amy understands firsthand the challenges individuals and families experience seeking appropriate care. Sallie Rediske, MPT, was in private practice for 18 years prior to MECFS requiring her medical retirement. She was nationally board certified in women's health, physical therapy, and specialized in the treatment of complex chronic conditions, especially those having a pelvic pain component. And our third speaker, Melinda Maxwell, pwME, worked in a variety of clinical settings with an emphasis in gerontology before she became medically disabled due to MECFS. She co-founded the Facebook group Physical Therapist, Occupational Therapist Resources for treating MECFS, and serves as co-administrator along with Sallie Rediske and Amy Mooney. Welcome to you three, and thank you so much for presenting to us today. And with that introduction, I will hand it off to Amy.
Very good. Let me share my screen. Oh, is my screen up on my first page there?
Yes, we can see
Okay, good. So welcome everybody. Thank you for joining us today. We're really excited to be presenting, and this is, I think, vital information that I hope that is going to be helpful and informative. So we are going to be moving a little bit fast, so I really do recommend taking Karen's advice at pacing, coming back, and this is going to be recorded, so using the information in bite size. So do what you can to protect yourself for your needs. Let me see. Why is this not? There, sorry. Now I'm probably going to move. So this presentation, the outline is we're going to look at OT and PT traditional guidelines. And then we're going to go to flipping the iceberg for PEM, severity symptoms of ME, pacing for PEM, and then task analysis. We're going to look at some activities and tasks and analyze them through the OT and PT perspective. So Sallie, Melinda, and I are here to tell you that MECFS and long COVID with post-exertional malaise is not deconditioning or functional neurological disorders. It is not the inability to deal with life's stressors, anxiety, avoidance, or all the other excuses that diminish and marginalize the complex multi-system disease that completely robs and alters the lives of millions of people. So MECFS is a real disease, and the people living with ME need a cure now. There's currently no FDA approved treatments for ME, but we do know what can help, And we absolutely do know what cannot help and what actually is harmful at times. You probably have heard of graded exercise and cognitive behavioral therapy, but we are here to say those are not treatments for people with ME. Cognitive behavioral therapy and graded exercise therapy, they ignore the broad evidence of neurological and immunological and the energy metabolism impairments. It suggests that MECFS, fatigue, and disability are the result of inactivity and deconditioning, and they fail to improve functioning and are detrimental to the health and well-being of the patient population. Graded exercise is a method or a strategy for increasing exertion or duration over time. And the goals are to be measured in quantity, and we are not looking at those for people with ME. We're looking at fatigue, and not all fatigue is ME. And the ME community has many examples of these terms as being haphazardly used, which only muddies the waters even more for the subject pool of ME research. Fatigue is being tired, and it's the normal response to life circumstances. It's being tired after a long day's work. Chronic fatigue describes a symptom of many number of chronic illnesses. And chronic fatigue syndrome is the name that the CDC gave to the outbreak of Incline Village, Nevada. And in 2015, the IOM report concluded that the term stigmatizes and trivializes and should no longer be used. Post-viral fatigue or post-infection is the tiredness or weakness that lingers often for months after a person has fought off an illness. And it's very common following infections over time, and typically people return to full health. And history has shown that the outcomes of post-infection, such as SARS-CoV-2, that there are two categories that we need to consider. Those that have just post-viral fatigue, and those that do have post-viral, have long COVID with post-exertional symptom exacerbation, which can be meeting the criteria for ME. And from here, I'm going to then continue. I'm not going to refer to it as post-exertional symptom exacerbation. I'm going to now refer to it as PEM for this presentation. And post-exertional malaise, what is it? It's a crash. It's a relapse. It's a collapse. It's where all of the symptoms come running over and flooding a person, drowning them in cement. These symptoms all roll over. And a person might describe PEM as having run a marathon with the flu and hungover and getting hit by a bus, all of it together. It's described often as being poisoned. PEM is the worsening or the exacerbation of a patient's symptoms and functioning after exposure to exertion. And that exertion is sensory, cognitive, emotional, and physical. They're all stressors that were previously tolerated. And PEM may be immediate or following exertion, immediately following exertion, or delayed for hours or days. And PEM can be episodal. It can be one event causing a response, or it can be cumulative and multiple stressors adding up to a PEM response. Patients can experience an exacerbation of one or all of their symptoms and a further reduction of functioning. It may take hours, days, or weeks or longer to return to baseline, and sometimes a new baseline is now established. The symptom exacerbation is out of proportion to the stressor. and the symptoms are unexpected. You don't expect to get a sore throat by just doing computer work or feeling like you have the flu after just picking somebody up from school. ME is not being tired or worn out or sleepy. It is not deconditioned or out of shape. It is not having fears or anxiety over activities, but it is exertion intolerance. It's the worsening of symptoms following any stressor, and it's the inability to produce energy on a cellular level. So what do we do about it? What does OT and PT look like for people with ME? And how can OT and PT support people with ME? The holistic perspectives and philosophy of OT and PT are well suited to offer people with ME the support for restoring, rebuilding, and redefining occupation loss during the unique characteristics of this disease. The goals of OT are to participate in meaningful and purposeful activities. Occupation is meaningful when it allows an individual to fulfill a goal that is personally or culturally important. And occupation is purposeful when it is determined by the individual's unique needs and interests, particular to the environmental context. It is not other people's purpose. It is what the individual needs to bring to their own quality of life. And the goals for PT are preservation, restoration, or enhancement of functional and personally relevant movement. PT addresses components and the skills needed to perform functional tasks such as walking, standing, sitting, and transitions such as rolling and sitting or sit to stand. And goals should be patient-specific, addressing personally relevant movement for improvement of quality of life. And I'd like to think of OT and PT as working in tandem. They complement each other. Traditionally, PT might get a person moving and OT will get them doing. We will often see them working as a team, and they can work on their own, but often as a team and overlapping in the goals and the activities, but each are using their own specific guidelines to focus the treatment. So being an OT, I'm looking at the unique qualities of occupational therapy. And here's just a little bit of background about OT. The evaluation piece is examining why an individual is not able to do the things that you need to do to get your life in action. What's getting in the way? The evaluation uses an assessment of, say, motor, cognitive, sensory. There are more things to it. And then identify what supports and barriers might be in place from getting the people to do their things. And then using frames of reference to set therapy guidelines. So the frames of reference is once you've determined what the deficits are, looking at using structure and guidelines such as sensory integration or neurodevelopmental treatment, proprioception, biomechanical, cognitive behavioral. Those are all kind of the framework for what people are needing to be able to perform their activities. And then the goals are to support an individual in meaningful and purposeful occupation and improving quality of life. So traditionally, I think a lot of you have experienced OT or PT in some part of your illness journey, and sometimes have said, I've heard this often. What is being done in the traditional settings is not working. And why is that? Well, I believe it's because of this traditional OT-PT guideline approach. Traditionally, OT and PTs will focus on the deficits that present in therapy, what the therapist observes. So what the therapist sees when the client enters the clinic is typically what the goals are going to be set at. So it's the tip of the iceberg, more or less. And the goals of the treatment focus is to improve and increase activity performance, which then would lead to restored health and functioning. The traditional strategies are modeled on the assumptions that the physical components, which are increasing strength, range of motion, and endurance, and then the psychological components, which are the coping strategies, illness beliefs, will improve functional outcomes. But the assumption is only accounting for the observed feature or the tip of the iceberg. There's a whole extra hidden beast out of view of this disease, of ME. And the exacerbation of symptoms and the crash will happen away from the public's view. Patients will self-report fatigue and a slew of other symptoms that prohibit them from performing their activities of daily living and their occupations being a sister, a mother, a brother, a gardener. Those are their occupations. Those are the qualities that make their life meaningful. And what they can do in the clinic are able to be observed, but it's not able to be maintained and carried through the rest of their functioning day or week. Patients are too unwell to typically maintain a therapy schedule, and the therapist often assumes that the patient is well and off living their life or is not interested in therapy and discontinues service. But when you flip the iceberg, and this is the type of framework that I've looked at, is flipping the iceberg and deciding what's the hidden beast. Focus on the hidden beast under that's typically been out of view. And what you see are the hallmark symptoms of ME. That's the PEM. This flipped approach focuses on what was once below the surface and submerged. What is seen in public life or the clinic is not the essence of the disease. Improved quality of life will only happen when treatment and care and support is focused on the flipped side. The essence of PEM is what is happening after the activity and what is happening during the recovery. That's the essence of ME. The focus of OT and PT is to set the goals and measure the outcome on the recovery, not the activity. And here are the PEM sensitive guidelines that I have developed. PEM needs to be identified. You need to determine who has it and who does not have PEM. After identifying PEM, you look at the symptoms and the severity. Then you determine what the core occupations are. What is it that the patient wants to do? What are their priorities? And then looking at the development of a treatment plan within the limitations of PEM. Look at the symptom management, pacing for PEM, modifications and adaptations, and patient and caregiver education. And by using the strategies, the frames of references, that should help develop the comprehensive approach by already identifying what deficits are in hand. You can go through and set up the individual treatment approach using their frames of reference specific to their needs. This is not a cookie cutter type of therapy. And then utilizing guidelines that already exist for comorbidity or comorbid conditions, and heart rate biofeedback approaches all help support the treatment approach. This is a personal model of care, and it needs to be done very sensitive to the individual's needs. So this is a screening tool from the clinician.
Okay, I could see Amy, but I can't.
It's a clinician coalition, and it is determining PEM for different categories of fatigue. And do you have fatigue of exertion intolerance, or do you have fatigue that is considered dysfunction of the metabolism? So these type of questions help at least screen who has and who does not have PEM. Asking what happens when you engage in normal or previously tolerated physical and cognitive exertion? And how much activity does it take to make you feel ill or trigger illness worsening? How long does it take to recover from physical or cognitive effort? And do you avoid or change certain activities because what happens after you do them? And we encourage you to keep a daily diary of these symptoms and activities just to help you describe them and be able to see it over time. So this slide looks at identifying PEM, looking at determining the severity. Are they mild, moderate, severe, or very severe? And which in each of those levels, there are two components that need to be described. What is the quantity? What is the quantity of the battery charge? Is it 20% or 50? And then what is the shutdown point? Or what is the threshold? We'll go into this a little bit more later. And then quality, how sensitive is it to exceed that threshold? So if somebody is moderate and never experiences a charge of more than 50%, the next factor to determine is the sensitivity of the exertion threshold. Does it just take a little bit of exerting to bring you to your threshold limits? And are you at a fragile or stable severity level? You might be mild or moderate, but if you're very unstable, that's in a dangerous zone. But if you are stable in a moderate, you can actually predict what you might be able to do in a timeline. So understanding if you're fragile or if it's very unstable within those thresholds. And then identifying your primary symptoms. What are the symptoms? Make a list of your top list of your symptoms and look at it as a kind of as a magic wand. If you could take away a few, what would they be? Start prioritizing just to see what is making your life more disabling and dysfunctional due to your symptoms. And throughout the entire process, keeping core occupations as your main focus. How are these symptoms affecting the ability for you to perform purposeful and meaningful core roles? Determine what are the essence or the core occupations and taking inventory of those, such as are you a child, a student, a mother, a father, like I said before, a gardener, a painter, picking what are the core things that you want to add back to your life. Symptoms, and just going through these briefly, because I know that everybody's pretty aware of this. The core symptoms, looking at post-exertional malaise, are often unrefreshing sleep or sleep problems, concentration or cognitive impairments, pain, light sensitivity is also considered more of a hypersensitivity because it's not just lights, it's auditory, it's touch, it's taste, it's smell, all of the hypersensitivities. Abdominal or GI issues, and then also looking at lymphatic systems, having maybe sore lymph nodes, sore throat. So those are kind of the core pieces of them, but then also looking at the additional symptoms being motor perceptual, motor planning, or having poor body mapping, not really understanding where your arm is compared to your shoulder, maybe being a little bit uncoordinated, but it's really motor planning and proprioception that are involved. And then also orthostatic intolerance. And using the frames of reference, if you listed and take an inventory of your top symptoms, looking at what types of frames of reference can be added. Can adding a sensory diet be added to be able to control some of the things that are most symptomatic in your body? So that would be under sensory integration therapy, or maybe more cognitive impairments and looking at frames of reference that include cognitive disabilities. And common comorbidities, just very briefly through this, because there are so many things that can overlap with ME. Mast cell activation or small fiber neuropathies, POTS, cervical instability, Ehlers-Danlos. By giving some structure and taking some inventory of your symptoms and looking at the comorbidities, there are already protocols that can be added to your care. So talking to your doctor about comorbidities and also using some of the strategies that already exist for example, for POTS, using compression garments or having your feet elevated while you are doing different tasks. Those all are things that already established, and we know they make your quality of functioning a little bit better. And I just want to show some faces behind some of the patients that have ME. This just looking at the function of the pictures, this might look like mild, that patients unfortunately just go missing from time, but when they are in the public view, they look like they're functioning. They look like they're doing what they need to be doing. They're mobile, they're self-caring. They're able to manage light domestic and ADL tasks with modifications. They're able to be employed or go to school, but with modifications or shortened work schedules. And then significantly reduced activity with frequent breaks. Moderate, they have reduced mobility and may use mobility devices for energy conservation purposes. Typically about 50% reduction in pre-illness activity, unable to work or attend school full-time. They might be using home tutoring services. They may require extended rest periods, multiple days between activities. And I like to think of it as being more home tethered. They can't get too far away and they need frequent check-ins because they're just not able to extend further than home. And severe, able to carry out minimal ADLs with moderate amount of assistance, requiring daily caregiving assistance, severe cognitive difficulties, decreased information retention, and deficits in short-term memory and word finding, may need support for positional and movement, and then homebound and often bed tethered. And then very severe, unable to mobilize or carry out any ADLs for themselves. They need physical assistance with basic functioning and position care. They're often extremely sensitive to stimuli, and they're bedridden and limited with bed mobility. They need help moving even within the bed, and they need to be supported at all times with pillows and bolsters. And they're extremely fragile for every type of movement. And I want to thank Amanda Francie for this graphic. I want to remind you of the elephant in the room as being PEM. It's the hallmark symptom of ME, and once the threshold is passed, all of the symptoms come crashing like a tidal wave. It is vital to avoid the crash. Putting a body through a repeated cycle of the boom and bust is detrimental, and it should be avoided. Two important points for this is do not push through. Pushing through will exacerbate symptoms. And there's no guarantee that the individual will return to the pre-crash baseline and will potentially cause more damage. And wherever the battery level is in the charge, leave 30% for recovery. This is easier said than done. And how do you do this? You learn by pacing. So pacing is a strategy used for managing exertion over time. And there, to me, seem to be three categories of pacing. First is pacing for individuals without significant health concerns. That's pacing what healthy individuals might do to get through their day and not need extra help with rest, but just getting through their day. And then there's pacing for therapeutic strategy. And this is for the individuals with intact metabolisms, but they may have a disease or an injury that limits their motion and their movement. This strategy of pacing is complex, but it can be done and it can be taught by medical professionals, typically in a therapy setting, in a rehab facility. But pacing for PEM it's for the disease of impaired functioning. Pacing for PEM is complex, it's specialized, and it's absolutely vital for managing tasks and exertion and the recovery over time. Pacing for PEM must account for exertion prior to the task, during task, and post-task. And pacing for PEM is a lifestyle. It's a lifestyle of symptom management. And here's some examples. For pacing for PEM, I'm going to look first at the task analysis. What are the jobs you need to do or want to do? For an individual with severe and very severe ME, the task typically involves basic units of living, such as grooming, feeding, toileting, communication, expressing your needs. The task analysis involves taking inventory of the must-dos, the might-dos, and the may-dos. What is the top priority? And where's this task on the list? Is this task meaningful? If it's not, then that needs to be lowered down on the priority list. And then looking at activity analysis. This is the process of breaking the tasks, such as grooming, into the individual activities, such as brushing your teeth, washing your face, combing your hair, and determining the conditions necessary for achieving this goal. So such as, can I skip part of the activity? Do I really need to do it all now, or can it be done later? So this analysis includes breaking the components of the activity into the time, the physical, and the environmental context. And I'll go into that with another graphic. It involves planning and pacing. So what will it take to get this task done? And what does cleaning the mouth, what does brushing the teeth actually look like? What's the criteria? Is it just rinsing the mouth with mouthwash, or is it actually using a toothbrush and toothpaste? Could a dissolvable mint strip be used? What is the criteria for that task and for that person's severity level? And then pacing. How can I get this done with what I have now? What is my energy and my symptoms that I have now? There are no rules or a timeline to get these activities done. And then finally, the modifications, the adaptations and modifications are the provisions or the changes to the environment and the activity to help get the task done. And then the modifications are to actually meet the individual's needs. You might need to change the criteria, such as for a student, not giving as many questions to show that the student knows the material. Or, like I said before, for brushing your teeth, might not need to do the full action of brushing with a toothbrush, but modifying the activity. And then briefly going into the activity analysis components of it, we're going to look at taking inventory of your symptoms you can now look at a pattern and identify and begin to manage these symptoms. So each activity has stressors. Are certain activities more physical or cognitive or sensory demanding? And how will they affect your symptoms? Here's some examples. So think about the task of grooming again. And one activity within the grooming task is the priority of brushing your teeth. So I want you to think about where this task is taking place and what the sensory, what are the visual things that are going on in this room? What are the auditory components? Are there loud sounds around with water running? Is it in a loud and busy area? What's the touch like? What is the smell of the room or the environment? Is it near the kitchen? So you're actually getting a lot of smells from the kitchen. And taste, is the toothpaste super minty and intense? Those are all sensory pieces that can drain your system. And then proprioception is a person that is severe in the bed, having to really reach and use their arms when by giving them support, they're not needing to move as much. So proprioception also fits in the sensory components. Cognitive, what is the memory and learning process? The language, are there a lot of commands that are coming on to the person? Or executive functioning, complex attention, social cognition, and visual perception? Is the area that the person is working in a very overstimulating visual location? And then also physical. What are the gross and fine motor components that the person is being asked to do? Autonomic regulation. Is the individual really fighting to keep their temperature regulated? Are they working hard to keep themselves warm, or are they overheating? What is their position like? Are they having to reach for objects? Are they having to move through space that takes a lot of exertion on their physical being? And then social emotional, meaningful and purposeful. This needs to be something that is going to bring satisfaction to the person and give them a high level of priority for this task. So for this, I want to return, we're going to go back into this, but for this piece, I want to let Sallie and Melinda talk a little bit about pacing strategies that involve the heart rate biofeedback component. So Sallie and Melinda, take it away.
Thanks, Amy. So we like to call heart rate pacing, heart rate biofeedback pacing, because it emphasizes the learning that comes from the process of monitoring. Oops, can we go back one second? Sorry. That's all right. The monitoring that, the learning process that comes from monitoring one's heart rate. Heart rate biofeedback pacing is a tool that you can use to develop internal awareness of the effort to set boundaries for energy usage. The goal of heart rate biofeedback pacing is to move from hearing the screams of swollen lymph glands, flu-like aches, muscle and joint pains, headaches, debilitating cognitive impairment, and other really loud symptoms that scream at you, to being able to hear the subtle whispers and changes of things like changes in your breath, subtle changes in your heart rate, and to begin to identify other individual subtle symptoms that warn you of pending PEM. For example, some people notice symptoms such as becoming more irritable or lightheaded, or having almost like an aura-like feeling before they start to notice their heart rate changing. Each person may learn to tune in to uniquely personal symptoms that clue them into the pending PEM. Heart rate biofeedback pacing is based on the premise that keeping your heart rate below the anaerobic threshold optimizes the use of the anaerobic metabolic system, due to the fact that people with ME, the aerobic metabolic system is broken, and despite the system's efficiency in healthy individuals, it is incapable of meeting the demands, the metabolic demands of those of people living with ME. So we preface our comments here by saying that heart rate biofeedback pacing requires a certain level of cognitive energy and financial investment, and for the technology that's required. And so it may not be for everyone at this specific moment, and it may not ever be right for you. So don't take this personally, and don't take it on as something that you failed at if you don't decide to do this. You can also, our goal here is to provide you with information so that you can have kind of a gold standard to start with, and then you can modify and pick what works best for you. So much of the lives of people with ME are spent pushing back on being told what we're doing wrong, what we're doing too much of, and what we're not doing enough of. And so you need to pick what's right for you, and it's just a tool that's there if you want to use it, and if you don't, that's fine. There are several key points we want to make here. Also, heart rate biofeedback pacing is focusing on the physical aspects of your life and don't typically capture the emotional nor cognitive part. Secondly, there are individuals who have found other ways to effectively pace, and we encourage them to continue to do so, because changing takes energy, and you don't need to use excess energy when you've already found a system that works. For more severely impacted people with ME, heart rate biofeedback pacing may not be a method to record so much the response to physical activity, but rather the body's response to the environment, such as temperature, barometer change, noise levels, introduction of new foods or medications. A lot of the sensory things that Amy talked about that were in the first column that she was talking about. These things may drive a shift in someone's heart rate in surprising and unhelpful ways. Using a monitor in conjunction with a log, an activity log, whether it's a true activity log or whether it documents events and outside things that have triggered your heart rate change, can be a really powerful tool. And lastly, Todd Davenport from Workwell said that heart rate biofeedback pacing can be viewed a lot like taking on an exercise program when you go gangbusters in January thinking you're going to start a brand new exercise program. Great intent to stick with it for the whole year. And as the months roll on, you lose interest, you lose focus, you lose commitment, and things just don't play out the way they started out by March or April. It takes time, investment of energy, and personal commitment to actually do heart rate biofeedback pacing. Just like exercise, you can be a dabbler, or you can dive in deep and head first and do it very aggressively and very detailed. And your personal commitment generally plays out in the benefits that you receive from it. But know that whatever you do with it is what you need to be doing with it, and don't let other people tell you that you're not doing enough or you're doing too much or whatever. It's really important that for us that you understand that this is a tool and it's not a right or wrong sort of thing. We want to also just say that, you know, we've used these strategies for a long time personally, and we do advocate them, but we believe that you will find the best way for yourself as we go forward here. Next slide.
How's everybody doing? Let me take a deep breath. Okay, so what I'm going to talk to you about before we get specifically into heart rate biofeedback pacing is we want to talk a little bit about the different stages of PEM. This is an excellent handout produced by Workwell Foundation. It's free on their website. You're going to hear us mention them a lot today. They've spent decades studying why MECFS patients' aerobic systems are broken. And I encourage you to go to their website and look at all their videos and handouts and everything. So as we're trying to help you move from the screams of having overdone it to more of learning to listen to those whispers that your body is telling you, a good guide is to use this time course. So if you look at the immediate symptoms listed under the PEM time course, you'll notice that fatigue and being out of breath and maybe nauseous are the main symptoms. As you move into short-term PEM, which can happen immediately or be delayed, there may be more pain, brain fog, you may have headache, you may have sleep problems. And then long-term PEM, which can last over a week, sometimes a month, or can be constant. That's when you really start to experience the immune type system responses. You may have the sore throat, the swollen lymph glands, and just really, really feel unwell. So as we talk about heart rate biofeedback pacing, if you can start to tie that in with the first symptoms that you feel as you're getting close to or entering post-exertional malaise, then hopefully it'll give you greater control of your symptoms. And that way you will not feel that you are so much ruled by your symptoms as that you are working with your symptoms. Now, if you look on the right side, this is called the Borg scale of perceived exertion, or the RPE, rate of perceived exertion. They're different versions of this scale. This particular one starts at 6. And if you notice, 6 correlates with 6 and 7 are very, very light. So if you think about what you're doing, and if you feel like it's very, very light, then your pulse is probably around 60. That's how this particular scale works. Once you begin to start feeling that an activity is not very light anymore, one of the first things that you may notice is the very, very light symptom of breathlessness. And that is a sign that you are reaching your threshold, that if you cross over, you may experience post-exertional malaise symptoms. Next slide. Thanks. Okay, so now I'm going to talk a little bit about pacing, biofeedback pacing with a heart rate monitor. I want to say this to you. If you have been pacing with a heart rate monitor for a long time and you feel like it is working for you, keep doing what you're doing. We are not here to try to spring some new information on you and cause distress. Just keep doing what you're doing. If you've never tried it before, we encourage you to consider it, because it does help. So heart rate biofeedback pacing is used so that we learn when we're approaching our anaerobic threshold. Well, what is the anaerobic threshold? In patients with ME and some patients with long COVID, the point at which your body can convert oxygen for energy doesn't work. And it's also lower in MECFS patients. So in the absence of a 2-day cardiopulmonary exercise test, or a CPET as it's known, we have to kind of get an idea where we need to start so that we set our alarm, because if we go over that alarm, then we might be getting into PEM. So for example, my CPET result was 106. So I set my alarm around 100. That way, if it goes off, I know I'm getting close and I want to move back a little bit. Again, Workwell has done a lot of research, and they recommend, this is the recent recommendation from Workwell, is to do the resting heart rate plus 15 beats. And they go step by step in this handout, which again is on their website that you can print out. Now, I know a lot of you are thinking, if I do resting heart rate plus 15 beats, I won't get out of bed. And we hear that all the time. It is merely a starting point. A lot of you may have been around when there was the formula 220 minus age times 50 or 60%. Workwell does not recommend that, because that is based on healthy adults. And we know that in MECFS and long COVID that the aerobic system is damaged. But if you've been using that formula and it has been working for you, then keep using it. This is mainly for people who have never used heart rate pacing before and who want to try to incorporate it into their lives. So again, it's a starting point. If you're on a beta blocker, or if you have POTS or other dysautonomia symptoms, then you're going to have to play with the number and get a starting point where you feel like you can do a little bit, and then just pay attention to your symptoms. When the alarm goes off, how do you feel? Are you getting breathless? Because again, we're trying to get you in tune with those subtle changes in your body systems that are alerting you that something is happening. You're reaching the point where if you go over, then you're going to have some post-exertional malaise. So again, so that it's more, you can stop, rest, and hopefully not set yourself up for intermediate and long-term PEM. Again, working towards the immediate symptoms. There are different types of devices to use. The most accurate is a polar chest strap. Many people use those, and they have an extra strap. You can wear them in the shower, gives you immediate feedback, and it is the most accurate. A lot of people just don't like how they feel, how they're cumbersome. You know, there are lots of different wearable devices. I personally use an Apple Watch. That's just my choice. I progressed from a strap to a Fitbit to an Apple Watch. But because a lot of people have decreased blood flow in their extremities, they may not be as accurate. So that's one thing to keep in mind. And now on the other side of the screen, I just want to give you an example. If you look at the top graph, the pulse there is mostly in the 70s. And then every now and then you'll see a positional spike, and then the pulse drops back down. That is usually what happens when you have POTS and you change positions. If you'll notice, you know, like if you're lying down and you go sit up and then stand, your pulse will spike, your alarm will go off, and then everything will just sort of calm back down. That's a physiological response. That's not the same thing as going over your anaerobic threshold. But if you look at the graph below that, you'll see that the pulse starts out around 70, but then all of a sudden, after a while, it starts getting up around 100 and even higher for a sustained period of time. And that is going above the anaerobic threshold, and most likely PEM will be induced. And I do want to say again that this is just an introduction to heart rate biofeedback pacing. We know that there are a lot of conditions, especially POTS, that play a factor into being able to do this. And that is beyond the scope of our introduction today. But we are aware of that. And yes, there are ways around it. But that is just a brief introduction of listening to the whispers that your body is saying instead of the screams.
So don't let this screen overwhelm you. It's putting it all together. And ideally, heart rate biofeedback pacing will include the use of an activity log, the rate of perceived exertion, the time course handout from Workwell, and the heart rate monitor with the ability to look back and see it, the record of your heart rate over time. This is kind of the gold standard again. So you can pick and choose if you want to go full bore or if you want to just take little bits and pieces of this. The activity log is one that I found over the years that works best for me, and it's by Dr. Allison Bestad. Other people like to use apps that document. The main thing is that you can just look at stuff over time and be able to see pattern recognition. What I want you to notice here is that as the beginning of the week started, I have each color, for me, color stands out and helps me identify patterns better than anything. So I am able to, thank goodness, cognitively go back and look at my charts this way. Can't do them all the time this way, but sometimes I can. And so blue is deep rest, meaning that I'm lying flat. I'm not looking at anything. I've got sound turned off, quiet, resting. Green is a supine activity. I might be watching TV or listening to an audio book. Yellow is a physical activity of some kind. Cognitive activity is orange, and PEM is red. I am personally affected more by cognitive activities than I am by physical activities. I can bring on PEM quicker with a cognitive activity. So the first day of the week, I did some cognitive work on the computer and brought on some immediate PEM. As you can see, I used the time course handout, looking at it, and identified that I had some really quick onset whispers of PEM. And I went and took a break and got out of gravity and took some rest. And then the second day, I had some periods where I had a longer physical event than I really anticipated. And by the third day, I had some PEM that I woke up with, and I realized that I was not doing what I needed to do. And I was looking at my trait, I was looking at my heart rate monitor, it was going off more than it should have been. And I began to add some more green and blue into my activity log. And the whole time I'm keeping in mind the rate of perceived exertion. I'm trying to think about what the colors, like, is this activity keeping me down in the lower part of that graph, that chart, with the very, very light and the very light activity? Or am I creeping up into the fairly light where I know I'm going to be above 100? So you can see that I did exceed my heart rate in the middle of the week. Usually as the green and the blue was added back in, my heart rate got better, and I didn't have any episodes of PEM the rest of the week. The big thing here is to see that these three tools really help me internalize the awareness of the sensations of whispers of PEM. And if you're new to all of this, really be easy on yourself. I can't say this too many times. Realize that this takes time and patience. This has taken me a very long time to get to this point where I pull all this stuff together. Start with the activity log, I believe, is the easiest thing to do because it's very intuitive. Most people have the cognitive ability. Some people have the cognitive ability, but not the energy to actually produce the log, but they understand what it's for. So that's a good place to start. Then learn how to integrate the rate of perceived exertion scale. Start to understand why it's 6, 7, 8, 9. That means 60 beats per minute, 70 beats per minute, 80 beats per minute, 90 beats per minute. That's where you want your heart rate to be, down in that range. And then start looking at the PEM time course and start really understanding what immediate and short-term PEM feel like, and understand those symptoms and identify where are you feeling the whispers? Or are you down in the long-term PEM? Are you staying in long-term PEM? Maybe you're always in long-term PEM and you don't even recognize it. Can you catch yourself when you move from immediate into short-term PEM? And then the very last part is probably the least intuitive part, to me at least, is to then add in the heart rate monitor and get one with a audible alarm that does alarms in real time. And then you can also get one that puts the data onto a graph so that you can look back at it and put all this together, and it helps you really, really learn what you're doing. You can take this and you can, like I said, use it all the time. For some people, that's just the way they live their life. From the moment they take this on, they decide this is going to be the way they run their life for the rest of their life with ME. I personally use it when I need to have a little tune-up, when I realize that I'm not feeling quite as well, or when I've had a significant shift in some type of part of my life where my baseline may have shifted and I need to heighten my awareness. So you can pick and choose how you use this. So again, can't say it enough. Don't bite off more than you can chew. Start small and take what you can and learn these tools, and then begin to put them together. Ask for help if you have a support team. And we understand the incredible difficulty in finding educated OTs and PTs. We'll talk about that probably a little bit later, but we hope to have you find some OTs and PTs that can help you find the right, that they can help you set this up. Any step in controlling PEM may free up cognitive energy to allow you to take the next step in using any of these particular devices. And then Workwell Foundation has videos on their YouTube channel and There are several good Facebook groups that also are really good at advocating and teaching this process. Back to you, Amy.
Thank you. So just looking back at this slide again, pacing for PEM, we've already looked at task analysis, activity analysis, which the heart rate biofeedback has a huge portion on being part of the pacing piece of the activity analysis, especially looking at the adaptations and modifications. Adaptations and modifications are simplifying the components of the activity, using flexible timelines and schedules, outsourcing or eliminating the work, getting things done by somebody else as much as you can, providing assistive technology, electric tools, remotes, timers, anything that you can do from your chair to get you turn the lights on, the TV, control anything you can with remotes and timers is really, really helpful. Also using recording devices, anything that can help simplify work, and then you can revisit the information that you might need with recording devices. Positional supports. I can't say this enough, with giving the body all the support it needs is so important, by even giving the support on arms, so that people can work on their hands and use their hands as their tools, and not having to weigh down the rest of their body with their arms or their back, getting them all the support they can use with pillows and bolsters, getting an adjustable bed so that you can be halfway upright to be able to watch things and do things from your bed. Wheelchairs, they're for energy conservation. They need to be used. And then also using commodes and bedpans and catheters for people that are severe. A commode is not something that should be looked over. I mean, you should really use a commode if you're counting the steps to the bathroom. It makes perfect sense that if you can use fewer steps by using a commode in your bedroom, you can maybe free up time and energy for something else that's going to be more important. Nutritional support, getting high quality food in. If somebody is crashing, they might need energy drinks. If they're in the middle of a crash, thinking about what foods take the least amount of work to eat. Soft foods, vegetable soups, and things that are not going to be exertional to get into your body. You just need the energy. You just need the high quality, energy rich foods to get in. So nutritional support is invaluable. And then we talked about during activity analysis and pacing, what it takes to get this done, and how can I do this with the symptoms and the energy that I have. Looking at this in a time, physical, environmental, and adaptation piece. Looking at time, what time of day are these activities? Can it be done every other day or weekly if it's necessary? Can each of these tasks be done in smaller units? And physical, what are the demands on the person? What is the setup that is going to take to do this task? Are you needing to reach a far distance to put dishes away? If that's the case, then leave them at the sink. You don't need to keep putting things away if you're going to be reusing them soon. And then what are the effects of the temperature in the room or the weather changes, like Sallie had talked about? Barometric pressure makes a difference on the body's system. So paying attention to what weather changes are coming so that you can plan for what might the afternoon look like if you're going to be suffering from a low barometric pressure change. And also physical also involves how a person's internal regulations are going on with even bowel movements. Looking at, if somebody's really trying to get to sleep, their body is still processing, and a bowel movement might actually be keeping them awake. So making sure that the individual has a plan in place for how to get their bowels moved, asking for medicine from the doctor, or just taking care of those things will affect how the person gets quality sleep, and making sure that the individual is well taken care of on the inside and the outside. And then the environment. What are the stressors in the environment? Are the lights bright and glaring? Are the sounds really not distracting, so a person is having problems concentrating? Is somebody in your life really wearing strong perfumes? Those are stressors that really drain a person's ability to process the information and focus in on the task. And also then analyzing all of these pieces will help by then putting adaptations and modifications in place. And I looked at this as for a person with severe ME, just looking at body washing. Time. Is it done every day, or is it every few days, or is it every few weeks? Is it one body part at a time? And is it the day, or is it in the evening? So looking at the time for this particular task to be done is very important. Physical, is it bedside? Is it in the bathroom, or is it in the room, in the bedroom itself? So figuring out where this task is going to be done, what type of support is needed to be able to clean a person, and for the caregiver especially, to limit the touch and let the person know that there's touch that is coming. I'm going to touch your shoulder now, giving them cues, using constant input instead of surprising sporadic input, really helps the individual know that they are going to be in a calm, quiet space. And then the environment, looking at the lights, the visual. Are there loud prints on the curtains or on the sheets? Is the caregiver wearing a striped, distracting shirt that is visually draining from somebody? Are there screens in the room that are on? Because that also is very draining. So just looking at all of the things that can take exertion from a visual perspective. Sounds. Is the caregiver using a very soft voice, or is it a very loud, kind of noxious sounding communication? Smells, and then temperature. And then adaptations and modifications, perform the routines in predictable timelines, and giving cues. Don't bring up new things when a person is already at their threshold. Wash individual areas or body parts. Use washcloths and body wipes. Use unscented soaps or mild cleansers. Have a short haircut. Sometimes hair care is really exhausting, and when somebody can finally get a haircut, it's liberating to not have to worry about having hair always tugged and pulled. And then using pads to keep the bed dry. And then caregiver is needing to give max assist so that the person is not needing to do any position changes. And this was given in the article, caring for patients with severe and very severe ME. These are just some examples of some of the modifications that can be used. Providing a shower chair, grab bars. A transfer board can be used for transferring into the tub or shower chair. Eliminate bathroom mats and rugs that pose a fall risk. So these are all just strategies, are all suggestions for modifying in an environment just for washing and grooming. And then this I had showed in a different graphic with the flipping the iceberg image. And it just looks at what the OT eval process and the PT eval process look like as identifying PEM, looking at severity and the symptoms, identifying the core occupations, and developing the treatment plans within the limitations of PEM. And then using the already existing protocols from comorbid conditions. And then finally, the pacing for PEM worksheet that looks at what symptoms and activity levels a person can go through and start listing what are some of the top symptoms that an individual may have, such as cognitive fog or exertion intolerance or fluctuating heartbeat, and then giving it a value just to make sure that you know that these are the top things in your list that you need to be cautious for when you are going to be doing activities. Like Sallie had said that some of the cognitive work is harder for her than physical work, and just making sure that people are aware that just by having conversations might be more draining than having to go for a short walk. That those are the things that really do drain from a person's system. And then looking at the task analysis, what must you do? Such as you must eat, you must toilet, you must change clothes. What may you do? Maybe wash your hair or play a game of cards with your kids, or make a phone call that you needed to make. Those are things that are important, and they're needed, but they're not in the must. I really, really need to do this. I need to eat, or I need to have my clothing changed. And then what you wish to do, talk to a friend, go get a haircut, or have somebody come to the house to give you a haircut, or even cut your own, or play the guitar. Those are all the things that you wish you could do. And then my suggestion is to make that on a timeline so that you can see, like Sallie had made, that over time you can make room on your schedule for some of those things that fall into your may do list or your wish do list. But even if somebody is going to say, I need to eat, but I really want to see somebody, putting those two together, having a social dinner is too absolutely draining. You need to separate those tasks out so that you don't overexert by just having one task you assume is going to be an easy thing to do. It's not. It really drains from two different systems. And then finally, the task analysis being time, physical, environment, and then the adaptations and modifications. And this one, if we have time, Sallie and Melinda, if you want to hop back in, we can just take a quick look at this and talk about how for somebody that has moderate ME, just for preparing a meal, just looking at what time a day this needs to be done is important, and how they're over time have looked maybe at their heart rate biofeedback. If you can say, you know, I know from my schedule, the morning is my best time. So maybe I need to do this in the morning, is prepare some meals for the rest of the day, and taking a little bit of scheduling for guaranteeing that you're going to go a little bit longer in your day as much as possible. So that's the gist of our presentation. We really want you to take to heart that the goal of OT and PT is to improve quality of life. All of these suggestions that we have given today are with the goal of improving your quality of life. And the treatment focus, how you do it, is by managing your symptoms, managing your activities within the limitations of PEM, and then restoring your autonomy, giving you the power to make your own decisions. These are your choices on what you want to do with your exertion that you have. So thank you so very much. This is the Facebook group that are for OTs and PTs to join. Unfortunately, it's not for patients, it's for peer-to-peer. that Melinda and Sallie created, and I was so lucky to be included in. So that's a really good resource.
And I want to say one caveat to this is because I think a lot of patients are really, it really hurts them that we don't include them in this, but I'm going to be very direct about why we don't, because patients with almost 100% certainty know more about their illness than any physical therapist or occupational therapist you will ever run into. And what happens is that the professions are unfortunately not ego-less, and they do not take well to people telling them that they don't know stuff. And so we've created a safe space for therapists to learn. And it's not because we don't want to share information with patients, it's because we feel that the only way that clinicians will reach out and actually try to learn, and unfortunately in many cases, is by being in a safe place. So please understand that, and please encourage any PT and any OT to join.
And I second that.
And there, thank you for your attendance.
Thank you so much for your presentation. It was really helpful to see all these different perspectives that you bring, both as experts in PT and OT, but also as people living with MECFS or taking care of people, loved ones that have MECFS. So I really liked that you were able to bring both sides of that to this presentation. And I think people are saying in the comments that they are learning new things even after living with this illness for maybe decades. So I think now we're going to open it up to some questions, and we might not be able to get to all of them, but our presenters have offered to answer some of the questions that maybe we don't have time for after this presentation. So if you don't get the answer to your question now, we'll be able to post some more information after our session today. So I think a question that I saw that came up a lot in this presentation is, how can patients find PT or OT professionals that are knowledgeable about this illness?
Sallie, do you want to take it?
Well, first you could actually contact us, and we would put it to our group and ask for someone in the geographical area that you're located in, and we can't guarantee anything, but we do know there we've learned people, so we do have a certain base of people that we are trusting. There's also some activity we're beginning to be aware of that's starting with a program that should be moving nationwide with a PEM virtual therapy program soon that we can put out there. Again, if you'll get in touch with us. And then the other thing is be a really strong advocate for yourself. When you call a clinic, tell them that you have MECFS and that you have post-exertional malaise, and you need to find out if there's a therapist there that treats that. And if the office staff is like, all fumbly and doesn't have a clue and doesn't refer you to someone, then that's the sure sign. But they may put you to a therapist, and then if the therapist calls and if you don't read the therapist really in a confident way, do not pursue it. And but there are some therapists that are really moving forward really fast fortunately because of long COVID. And the key things I would look for is if they identify treating MECFS on their website instead of chronic fatigue, if they offer virtual appointments, if they treat PEM for long COVID, if they say that, those would all be things that I would actually look for. And then don't be afraid to go to an appointment and get up and leave.
I'd like to
done it many times.
Yeah, good point, Sallie. I'd like to also add that MECFS patients and long COVID patients, they get regular orthopedic type cardiovascular and other issues too. So, you know, you may find yourself with a shoulder replacement or a knee replacement, or you have to have ankle surgery. Even with that said, though, post-exertional malaise overrides everything first. You know, it's not, you know, you may have a therapist that's crackerjack ankle therapist, but if they're not willing to learn about post-exertional malaise and how you're going to be affected by that, then I would think twice about working with them. A lot of therapists don't understand it or haven't worked with it, but they are willing to learn. And if you send them our way and we admit them to our Facebook group, we have a whole learning module set up to teach them. And there are a lot of PTs and OTs that are willing, but like Sallie said, you know, don't be by all means be your own advocate. And if you don't have a good feeling, and if they're asking you to do something that you know is going to put you in the bed, just get up and leave, you know. And that's the point too. If you can find someone that's willing to come to your house, or even better, work with you virtually instead of you having to get out, that would be the ultimate best, you know, step for a lot of people.
Yes, one also thing is I would ask that they listen to what your goals are, that you are not going to be swayed by them saying you're deconditioned and your goals need to be more strength or range of motion or something like that. I think by asking them straight out, by saying, what are the goals that you see working for me? And if they really are fighting you, leave. They're not going to change their mind. It's not worth you making the perfect therapist. Just that's when you have to get up and leave and protect yourself.
Yeah.
Thanks. Okay, another question that came up, or maybe this has different components, but with PEM, how do you handle that, or manage what is causing PEM when maybe your energy window or envelope is changing over time, or with PEM, there might be a delay in your symptom trigger and when you actually notice that you've exacerbated your symptoms. So maybe this question can be targeted for Melinda and Sallie, but what are ways that you have kind of identified what those triggers are when there's such a delay or when there's such variety in your symptoms?
I think that's when logging is really important. You know, you can create your own log. There's a great class online called it's Bruce Campbell, and it's cfsselfhelp.org, and on that website, it's a wonderful class for pacing. You can do it in a group or individually. There are lots of logs. You can print out a pacing log, a symptom log. That way you can record what you did, and then if you feel bad a couple days later, you know, you can look back. Was it, you know, that you overdid it just a little bit? You you know, you're in the kitchen and you wanted to finish what you were doing in the kitchen, and then, you know, learning that this was really hard for me because I'm somebody who likes to check off things done, is to learn to stop in the middle of an activity and to rest, you know, and rest meaning lie down flat, eyes closed, no sound, and then get back up and complete the activity. You know, things like that will help you over time be able to do things and hopefully not pay for it a couple days later. Or it might be a combination. You know, if you put like going out to lunch, you know, the sounds, the smells, the physical part, the mental part, the social part, you know, maybe you could just have like a picnic in the bed with one person to start and gradually work towards being able to go out so there's not so much stimulation.
And with the heart rate monitoring, I think a lot of the things that you were talking about were related to maybe physical things that folks are doing. But when you, for example, Sallie, when you were saying that cognitive activities really drain you, is that reflected in the heart rate monitoring, or does that look different than physical exertion?
Yeah, I've never seen any indication in any literature that it does, and I'm sure that emotionally, some of the emotional triggers would show up on heart rate, but that's the important part of logging, is because the cognitive piece is not picked up by the heart rate monitor. And so at least for most people, I mean, maybe there is somebody that it would be picked up. And I think that we have to recognize how much cognitive work we do, and how much, there's the old thing that I was taught in PT school, that the brain uses 25% of the body's energy, so it's sucking up energy faster than any other part of the body. And so just even subtle things like, scrolling on your phone is really using a lot of juice. And so you need to be really aware of that. And those kinds of things can wear you down a lot quicker than you realize, I think, if you're not attuned to it. And
Thank you. Okay, let's see. Amy, I think this might be directed towards you. So you talked a lot about different occupations, but with people living with this illness, there could be a conflict between what they really want to do, maybe like hobbies, like you mentioned, gardening or painting, and then things that might be obligations, like being a family member or a partner and wanting to contribute to, cooking or helping with the dishes or laundry. So do you have any practical tips for how people can balance, things that they want to do and things that they need to do, or to feel like, they're an equal partner or contributing as a member of the family or a parent or a partner, or things like that?
Yeah, I think the piece of it is that it's going to change the dynamic of the whole family unit anyways. That if somebody is, a mother that is now trying to take care of children with moderate ME, that I think that's the hard part. That's the emotional piece, that those parameters which you once valued as being, that mom that went to school pickup all the time, or was the one that everybody else could rely on, is now asking for help. And I think that's the emotional piece that is so hard to come by. But I think by redefining what it is that you want, what are your priorities? Your priority is time with your kids. So how are you going to spend that time? You cannot have it all. So how are you going to spend that time with your kids? And where is it going to happen? Is it going to be in a busy environment, or is it now going to have to be bedside, or is it going to have to be, mom laying on the couch while the kids are playing a game around them? Or, I mean, I even, family dinners don't happen anymore. I mean, you just can't count on everybody sitting at the table together. And so now you're thinking about, well, what is the core piece of a family meal? It's the social piece. It's not necessarily the eating. So take the eating part, take it out of the situation, and now have the social side as its own piece. If somebody's going to be celebrating a birthday, you want to have cake with that person. So instead of having that person come to the table and eat cake, how about everybody pick up their plate and go to where the person is laying in bed and eat cake sitting on their bedroom floor? I mean, so it's reimagining the emotional piece, but in a different environment. So that's the hard part, is trying to figure out, how do we emotionally separate what we want to do? Because we want to be able to sit together as a family, but that's not going to happen right now. And I need to be able to know that we're still going to be able to have quality time together, And now that quality time is, you know, everybody sitting on somebody's bed playing cards instead of, you know, sitting at a game table or something like that. Or so that's my, I guess, piece is you have to start reimagining what brings you the joy of your family and what your roles are in each of your occupations. Because for occupational therapy, occupations are not your profession. It's not how you get paid. It's how you live your life, your occupations of being a mom. And now that somebody has ME and they're a mom, how do you do that? And you have to figure out, I'm not going to make a 3 meals a day for my kids. I'm going to now maybe do 1 a week. And for that 1 a week, it's going to take me 4 days to prepare. And I'm going to savor those moments of trying to get that quality with my family. And you know what? It's maybe not going to be sitting at the table. Everybody's going to be, I made this meal 3 days ago, and now we're going to all sit in my bed and eat this meal. So those are the reimagining components that just are heartbreaking, but are the reality of ME.
And Sallie or Melinda, do you have anything that you would suggest or want to add?
I think not really, other than some really deep statement that ME forces you to come to terms with the belief that human life is valuable no matter what you do.
Absolutely. I agree with everything that Amy said, and also Sallie. Again, you know, you can break the task down, and you can increase your rest breaks before the activity that you want to do. Let's say you have something, and what's the most frustrating part about ME is never knowing how you're going to feel the day that you want to do something. So being flexible with that is takes pressure off too. But if you're shooting for an activity on a certain day, you know, try to rest, double up on your rest leading up to it. If you can, rest during the activity, and then rest a lot after the activity. By doing this, which I learned in that class that I mentioned previously, it was called special event planning. I was able to actually travel with my husband quite a bit, not too much flying or anything like that, but just like going to the lake for a week or whatever. I would clear my calendar the week before and rest up. We would pick a place and I would rest while I was there. And then I had my calendar cleared a week or 2 after I got back, and I did, you know, I rested after the activity. And I was able to do things by just pacing myself for the special event is what it's called. And, you know, maybe a special event like Amy mentioned was cooking a meal for the week, and you can use those same concepts to do that.
Thank you all for sharing those thoughts. And I'm seeing a couple of comments too in the chat that I just wanted to share too. That one person saying that ME people are creative in their solutions. Someone else says that we are all valuable. And I like this comment too. It says we are all human beings and not human doings. So something to keep in mind. Well, I think we're gonna wrap up now. I know that we're getting down to the end and we haven't had a chance to answer all of these questions, but we'll summarize some of these common ones that are coming up. And so if you didn't see your question get answered, we'll post the answers to those online as soon as we can. So I just want to thank you again. So give a big thanks to Amy and Sallie and Melinda. Thank you so much for sharing your time and your expertise with us today. And I learned a lot, and I think our audience did too. So I'm really grateful to you for sharing your time with us.
Thanks for this opportunity.
Yeah. So for those, you know, if you're still with us and you want to check out the video, or for those who had to take off, I'll just remind you all that we'll post the video on our website and on our YouTube channel. And We'll notify you all when it's up there so you can go take a look at and review anything that you missed or you want to go over again. And I also want to just remind everyone that our next Sunday conversation is next month on March 19th, the third Sunday of the month, and it will be at 4 p.m. Eastern Time. Our topic for next month is going to be a presentation of the broken Michigan, and it will be a performance and community conversation. So the Broken Michigan is a 23-minute theatrical work that follows author Sarah Nessen's compelling journey towards wholeness after being diagnosed with MECFS. So a little bit of a different topic next month that we're excited for and hope you'll be able to join us. Finally, if you have found this program worthwhile, there are a few ways you can help. So you can make a donation to help support this series by donating online at the website posted on this slide. On the same page, you can sign up for the MassME newsletter, so you'll hear about presentations like the one we had just now. And if you donate $25 or more and check the option for the box, become a member, you'll establish your membership, or you can renew it if you're already a member, and you'll be invited to some of our members only programs. I just want to thank all of you for coming again and hope to see you again next month. Bye-bye.